is going to be the effects of deadlift, squats, and hip thrusts on the spine. For those of you who don't know me, I'm Lauren, and I'm a third-year Western U student. So the objectives I'm going to go over today is the amount of force that can be placed on the spine without injury occurring, EMG activity of muscles involved with deadlift, squats, and hip thrusts, different variations of these exercises and how that changes EMG activity, shear and or compression forces placed on the spine during a deadlift and squat, and clinical applications for these exercises and their variations. So first is the amount of force that can be placed on the lumbar spine without damage. That'll be 36,400 newtons of compression force and 3,539 newtons of shear force. And just for comparison, a 4.0 earthquake in California is 58,839 newtons. LeBron James at 6'8", 250 pounds with knees flexed at 75 degrees generates a vertical jump of 4,903 newtons. A tackle from a defensive back at 5'11", 200 pounds generates 7,117 newtons. And a bat contracting a baseball generates an average force of 18,436 newtons and a peak of 36,982 newtons. So first we're going to go over deadlifts. So these are the different variations of deadlifts. We have your close bar deadlift or your conventional, which is the bar is positioned over the navicular. Bar bar is the bar is positioned over your third MCC joint. Straight leg or your Romanian deadlift, and then a hex bar deadlift. So for the muscle activation summary, all of the muscles that are highlighted on this slide are activated with a deadlift, and for each one I'll go through if there's a specific variation that causes greater amounts of activation. So first on the anterior side, we have our external oblique, which has the greatest activation with a conventional deadlift. The internal oblique also has the greatest activation with a conventional deadlift. The vastus lateralis has the greatest activation with a conventional bar bar and hex bar deadlift with the body positioned more vertical. The rectus femoris has the greatest activation during a bar bar deadlift and a hex bar deadlift with the body positioned more vertical. And the transverse abdominis is activated with a deadlift, but research did not specifically state if there was a specific variation with the highest activation. Moving on to the posterior side, the erector spinae has the greatest activation during a straight leg or Romanian deadlift, and a decrease in activation overall with the hex bar variation versus the barbell setup. And then gluteus maximus has the greatest activation with a conventional deadlift. And then our hamstrings, the biceps femoris, has the greatest activation with a conventional deadlift and a straight leg deadlift. And the semitendinosus also has the greatest activation with a conventional deadlift and a straight leg deadlift, but more so than the biceps femoris, and especially more prominent with a single leg. Next is the total amount of force output on L5-S1 during a maximal isometric close bar deadlift and bar bar deadlift. So Eddington et al. Looked at the shear and compression forces placed on the spine, specifically at L5-S1, during an isometric hold of the setup of a conventional deadlift. So they took experienced lifters, measured their 1RM, and had them hold a weight that exceeded that 1RM. So basically all of the forces that you see in this chart here are below the amount of force that can be placed on the spine without injury, except for the one circle here. And due to the positioning of the bar and muscle activation, the straight leg deadlift will have similar forces as the close bar deadlift. And then depending on body positioning for the hex bar, so either vertical or horizontal, it could be similar to the bar bar or the close bar deadlift, which then would influence the muscle activation. And also because isometric exercises we know generates the most amount of force, when a patient is going through these exercises, they're going to be going eccentric and concentric motions. So the amount of force that they're going to generate is not going to be nearly as much as the strength. Okay, next we're going to go into squats. These are different variations when it comes to knee positioning. So first you have a quarter squat, which is knees flexed until angles of 110 to 140. Half or partial squat, which is knees flexed until angles of 80 to 100. Parallel squat, where the inguinal hold is in a straight horizontal line with the top of the knee, and the knee is flexed until angles of 60 to 70. Then a full squat, where the thighs are below the horizontal plane at a tibiofemoral angle of 40 to 45 degrees. And then next is going to be different variations of how you can load for a squat. So you have a barbell front squat, barbell back squat, hex bar squat, and a box squat. And the barbell front squat is going to be similar to a goblet squat. Same thing for the muscle activation chart. All the muscles highlighted on this slide are going to be activated with the squat, and I'll go over different variations that activate those the most. So for the anterior side, we have the external oblique, which is activated with the squat, but research did not specifically say if there was a specific variation that caused the greatest amount of activation. Same thing with the internal oblique. For the vastus lateralis, the greatest activation is with a full front squat. For the vastus medialis, the greatest activation was with a parallel front squat. The rectus femoris was the greatest activation with a full front squat. And then same thing as the external internal oblique, the transverse abdominis did activate during a squat, but there was no research to state whether or not there was a specific variation with the greatest amount of activation. Moving on to the posterior side, we have the erector spinae, which is greatest during a parallel front squat. The gluteus maximus is greatest with a parallel front squat for the upper fibers and a full back squat for the lower fibers. And then the hamstrings, both biceps femoris and semitendinosus, are both greatest with a parallel back squat. So this is the compression forces on the spine. So Hartman et al. Looked at the amount of compression force placed on the spine during a quarter, half, and parallel squat by doing a literature review on relevant publications. So based on their literature review, they gathered data that included participants that were experienced in weightlifting. Their 1RM was measured, and 70 to 90% of that 1RM was used to perform 6 to 10 repetitions. And so from the surface EMG activity, they calculated the amount of forces that you see here. And then the forces would decrease for the hex bar front squat and goblet squat due to the location of the load. This is compression force and not shear force. And they also looked at the incidence of the risk of injury with the vertebral column with deep squats. So over a time period of 2.5 to 6 years, comparing competitive weightlifters to their age-matched controls, they found that there were no major injuries in the spine when looking at MRI scans. There was no disc abnormalities that were different. They were very similar. And then back pain was reported less in the professional weightlifters. So they concluded that intervertebral discs can adapt to exercise-induced compressive forces from weightlift training, which would lead to increased stress tolerance. Last exercise we're going to go over is the hip thrust. So these are the different variations of a hip thrust. There's the traditional or conventional, where the inferior angle of the scapula is on the bench, feet are slightly exceeding shoulder width, and feet are straight or slightly pointed out. The pull, the back is going to be positioned the same way on the bench. The only difference is that when the patient is going through this active range of motion, they're going to be asked to exert a voluntary internal force by pulling their heels towards their glutes. And then for rotation, the back is going to be the same as the traditional, but their feet are going to be wider apart. And then through the feedback of feel that your feet are rotating outwards, they're going to be allowed to move their toes out during the motion or start with their feet already outward. And then the last is feet away, where the feet distance from the bench is going to be increased by the length of a foot. And then the muscle activation summary. So first we're going to go through the vastus lateralis, which has the greatest activation with a rotation hip thrust. Vastus medialis has the greatest activation with a traditional hip thrust. The rectus femoris has the greatest activation with a traditional hip thrust, and this muscle is the least activated out of all of them for all variations. On the back side, we have the erector spinae, which research states that it is activated during a hip thrust, but there is no variation that causes the greatest amount of activation. However, when you're doing this exercise, if you have the chin tucked, that should deactivate the muscles enough to where the patients are going to state that they don't feel their back working, and they mostly feel their glutes and their hamstrings. Next is the gluteus medius, where the greatest activation is with a rotation hip thrust. Gluteus maximus has the greatest activation with a rotation hip thrust and has the greatest activation overall out of all of the muscles for all variations except for the feet away. So biceps femoris, the greatest activation is with the feet away, and this muscle is the greatest activated with that feet away variation out of all of the muscles. And semitendinosus has the greatest activation with feet away also. So next is the clinical application, so how these exercises can be included in clinical practice. So first we're going to go through some EMG comparisons. So this slide will show the exercise that activates the glute max, biceps femoris, and rectus femoris from least to most. So first is the glute max, least is with a squat, then it's a deadlift, and the most activation is with a hip thrust. Next for the biceps femoris, we have the least with a squat, then it's a hip thrust, and then the most is with a deadlift. Rectus femoris has the least with a deadlift, then a hip thrust, and then both is with a squat. There were no difference in EMG activity of the erector spinae for hip thrust and deadlift, and no difference in EMG activity of vastus lateralis for hip thrust and squat. So building a strong core, isometric versus dynamic training. So studies have proven that the stronger the core is, the lower the amount of back pain reported. And there are two different muscle groups that the core can be divided into. It's the local muscle groups, such as your feet muscles, like the multifidus or the TA. The global stabilizers, such as your superficial muscles, like the longissimus or your obliques. And there are two different ways that you can train the core. There's isometrically using a prone bridge or a side bridge, and dynamically using exercises like squats and deadlifts. So evidence has shown that there is an increased activation of external oblique, internal oblique, and transverse abdominis with exercises that incorporate instability. And instability just means like addition of a Swiss ball or an external load. Dynamic exercises without load, so body weight squats and body weight hip thrusts, and isometric exercises with a Swiss ball had similar trunk activation. So incorporating high intensity resistance paired with moderate instability, so now you're adding an external load to those squats and deadlifts. There was an increased activity of trunk region for dynamic exercise to a greater degree than isometric exercises. So their conclusion was that there were no advantages of performing a prone bridge compared to a squat when looking specifically at core activation. So next I'm going to briefly go over the different types of pain. So there's nociceptive pain, where it's pain originating from target tissues linked to occurrence of injury, inflammation, and repair with a clear stimulus-response relationship. There's three different types. First is mechanical, which is nerve endings may be mechanically distorted by scar tissue or abnormal pressure from tissues. Ischemic, where this occurs as a result of ischemia, altering physical and chemical environments of the tissues. Inflammatory, that relates to the inflammatory process in injured or diseased tissues. And then peripheral neurogenic is pain from peripheral neural tissue related to laceration, compression, overstretch, and or persistent presence of inflammatory fluids. Next is central sensitization, which is pain related to altered CNS circuitry and processing. And this is an enhanced excitability state that persists long after peripheral tissues have healed to the best of their abilities. Affective is pain arising purely as a result of emotional turmoil from inputs like loneliness, hopelessness, sadness, fear, anger, frustration, and maladaptive thoughts. And then autonomic and motor is pain from outputs via the sympathetic nervous system and the motor system. So sympathetic nervous system, that's our flight or fight response, and the way we think and feel influences the level of epinephrine and norepinephrine that's released. For motor systems, there's an ongoing tension in muscles from ongoing pain that may provide a provocative environment for further enhancing symptoms. So all of these types of pain, by definition, sound like they can occur separately, but they occur more like a pie chart. Much like the pie charts that we form when we're thinking about the impairments that our patient may have when it comes to terms like pain control, mobility, and stability categories. And depending how the patient presents that day, their pie chart will contain different percentages of these types of pain. And the loading using the exercises that I talked about today will be beneficial for strengthening tissues, which is the main goal of physical therapy, and neural pathways to the brain via mechanotransduction, so turning mechanical stimuli into electrical signals. And strengthening these neural pathways is extremely important when we start to think about fear avoidance. So whether the pain is short-standing or long-standing, there's going to be a period of time where patients are going to be afraid to move due to painful stimulus. But this becomes a greater issue when the patient starts to avoid movement altogether due to anticipation of pain and not the painful stimulus itself. And so this is the point where we can use these exercises to decrease that fear avoidance and teach them that moving into a little bit of pain and discomfort is still safe. So how are we going to load these patients, and how do you know if the load is enough? So that's when the repetitions and reserve come in handy. So the rating scale is a perceived exertion scale for resistance training. In the middle, we have a description of what that rating means in terms of repetitions and reserve, or how many reps do you think you can do after a set of 10 without stopping to rest? And then the last column is how you would know whether or not the load is too heavy or too light for that patient, or if it's just right. So for example, if somebody is performing a squat and you ask them, oh, how many more could you have done if I didn't stop you after the first set of 10? And they said 2, that means that the load might be too too heavy and they might not be able to finish 3 sets of 10 like we want them to, or they might only be able to do 8 reps the next set because of the load. Or if we ask them and they say, oh, I could have done 15 more reps, then that means the load is too light and the exercise won't be as challenging for them and it won't make those changes in tissue structures that we need to. So next are some patient cases, and these are from current patients and they gave me their consent to share their stories with you today. So first we have patient NS, who is a 56-year-old female. Her chief complaint is right-sided glute pain radiating down the back of her lower extremity to her ankle. Her medical diagnosis was back pain with right-sided sciatica. Her occupation is she's a stay-at-home mom, and her exercise level on evaluation day, she was sedentary due to pain and being afraid of falling. Her prior level of function before her injury was that she would go out on walks at least 2 times a day. Her mechanism of injury is she fell on both knees after tripping while ascending a flight of stairs at her doctor's office in November. Pain didn't start until a couple of hours later and she noticed swelling bilaterally but more on the right side. After the swelling resolved, the glute and lower extremity pain persisted and got worse over time. Her symptom pattern was mostly peripheral neurogenic, and her pain caused her to move slower and with extreme caution to avoid falling or breaking something due to a diagnosis of osteoporosis in 2017. And her goal was to decrease her discomfort, return to her prior level of function, and get stronger to decrease her fear of injury. So last week, we had her deadlifting 55 pounds. Hex bar squats were at 53 pounds, and she was just able to move that up to 63 pounds. And she was doing box squats with an overhead press at 15 pounds. And she didn't want to be recorded doing any of her exercises, but she wanted you all to know that after doing strength training, she has more confidence to lift heavier items without asking for assistance. So she wouldn't go to the grocery store or to Costco or anywhere by herself. And even if she was by herself, she would stop somebody and ask them to help her lift a case of water from the ground into the cart. Because she didn't believe that she could lift anything greater than 10 pounds. And now she's lifting more than 50. And I actually had her lift up the water cases that they bring. And she was able to do that 10 times, lifting it up into the chair and back down to the ground without asking for help, without being tired. Next is patient IA. He's a 21-year-old male. His chief complaint was low and mid back pain for 10 years. His medical diagnosis was spinal stenosis of the lumbar without neurogenic symptoms, juvenile osteochondrosis of the spine, unspecific. So his occupation is he's a physical trainer at the camp. His exercise level on eval day was light weightlifting, snowboarding, and boxing. His prior level of function was heavy weightlifting 2 times a week, snowboarding, and boxing, and he was able to squat 225 pounds, deadlift 100 to 145 pounds. His mechanism of injury was that his pain started while he was doing gymnastics, so he was a gymnast from the ages of 6 to 17 years old. And he only quit because of his back pain. So after he quit, he had pain on and off, but was still able to work and do heavy lifting. But 2 to 3 months ago, he felt an increase in pain after falling while snowboarding and has stopped lifting since. His symptom pattern was mostly nociceptive mechanical, and his goal was to return to heavy weightlifting and be able to work without feeling pain. Because at work, he's a physical trainer, so he had to demonstrate exercises, and he couldn't do that without feeling severe pain by the end of the day. And that severe pain was also keeping him from sleeping at night. So next, we have some videos of him lifting in here. So all of these lifts are going to be 75 pounds. So the first one, he's deadlifting 75 pounds. And notice how he's not overextending when he's on the way up, and his neck stays in line with the rest of his spine throughout the entire movement. Next, he's hex bar squatting, same 75 pounds. Again, he's not overextending at the top. He's light on his toes, and he's digging through his heels to lift the weight off the ground. And last, he is hip thrusting 75 pounds over here. So notice how his chin is tucked the entire time throughout the entire motion. He's not overextending at the back, and he's digging through his heels to lift the weight off the ground. And the most important thing is after physical therapy, he's had no more back pain while working and no more back pain that's keeping him up at night. The only thing keeping him up at night is the fact that he just stays up really late because he's 21. Last is patient DF, who is a 31-year-old male whose chief complaint is localized right-sided low back pain for 3 years. His medical diagnosis was chronic lumbar pain, disc degeneration of the lumbar. His occupation is he's a multimedia editor and developer. His exercise level on eval day was light weightlifting and cycling, and his prior level of function was heavy weightlifting 2 to 3 times a week. So he was squatting 225 to 315 pounds and deadlifting 225 to 365 pounds. His mechanism of injury was he pulled a muscle on the right side while deadlifting 365 pounds and heard an audible pop. Since then, he's felt pulling, stiffness, and tightness in his low back. His symptom pattern is mostly nociceptive mechanical, and he has stopped lifting altogether due to fear of hurting his back more, but his goal was to gain more confidence to be able to lift at the gym again without fear of pain. And he actually wrote something for me to say to you guys today after I asked him if I could share his story. So he says, I have been dealing with low back pain since I injured myself back in 2019 deadlifting. I must have let my form go and pulled my low back muscles. It was in the hospital after a CT scan that the doctor confirmed I have bulging discs and some minor degeneration. Since then, my back pain has ranged from tolerable to annoying. The days the pain became bad, I would take over-the-counter pain meds and place a heating pad on my back. I found on my own that stretching helped alleviate the pain. I focused in late 2019 after I healed from the initial injury on stretching and mobility drills before and after any lifting. Although the pain was somewhat alleviated during the stretching, it persisted after lifting. I took it as I was just applying too much shear force on my back when executing deadlifts or squats. I slowly started to do less and less of those movements throughout 2020. Plus, with the pandemic, it was hard to even get in front of a barbell, let alone into a gym. That year was filled with a lot of running, jumping rope, and HIIT exercises I could perform in my apartment's carport. Late last year, I started going back to the gym as they had reopened. Still, I strayed away from deadlifts or barbell squats. And even still, I had days of bad back pain persist. So I got another CT scan in early 2021. I still had bulging discs and there were more skeletal degeneration, but I was told these findings were relatively normal for anyone my age. It wasn't finding what was causing the pain. Turns out I was engaging my low back to perform moves like deadlifts and squats and never really turned on my glutes and hamstrings, which are vital to those lifts. I can blame my job as an editor for that, aka I sit all day. In physical therapy, I have learned that my form wasn't off, but I was performing small mistakes while deadlifting and squatting. This would throw off my form and force my low back to engage during the lifts, resulting in that muscle being overworked and constantly tight, causing my pain. Through physical training and training sessions with a personal trainer, I have pretty much started back with the basics, understanding and owning the movements for squats and deadlifts. And with taking the cues and techniques learned through physical therapy, I feel comfortable enough to get back to deadlifting and eventually squatting with weight. In fact, I have deadlifted in the gym after 3 weeks being in physical therapy. After warming up, I got to 265 pounds for 3 sets of 5 reps. Not my best overall, but not bad for no training for 2 months. After an injury and a bike accident. So he actually did have a bike accident 2 weeks prior to coming into physical therapy where he crashed into another cyclist. Ooh. And he ends with, I feel more confident knowing that I can still perform these big lifts while mitigating my low back pain. So here are his lifts in here. The first is he's deadlifting 225 pounds and he did this for 3 sets of 10. Oh. And again, notice he's not overextending his back on the way up, and his neck is staying in line with his entire spine throughout the entire movement. He uses more of a sumo deadlift style because that's how he's more comfortable performing the lifts and how he trains at the gym anyway. So we went with that style for him. Here he is squatting at 115. And again, his spine is staying neutral the entire time. And he's digging through his heels to lift the weights up, and he's light on his toes. And his goal for squats was to train for more depth instead of more weight. And last, he's hip thrusting 115 pounds here. His chin stays tucked the entire time. He's not overextending at his back on the way up, and he is digging through his heels to lift the weight off the ground. Now these next few sets of videos is what he sent me. So Again, one of his biggest fears was going back to the gym and lifting without somebody watching him the entire time. But here he is, the first time back at the gym. I can figure out what the mouse is there. So this is his first time back at the gym, 275. He did 3 sets of 4. Oh, just kidding. There we go. So 275, 3 sets of 4. And what you'll notice in all of the videos that are coming up is that his form stays the same, because what we were teaching him here was no matter how heavy the lift was, we were training him to lift 400 pounds. So even if it was 225, set up everything as if it's 400 pounds. So next here, he's doing 315. And 2 weeks ago, that was his 1 rep max, was 315. And again, the form is the same, and that's as heavy as he's lifted up until 2 weeks ago, since his initial injury. But today, he told me that he went to the gym on Monday. He sent me a set of new videos. The first one, he's at 295. He did this for 3 sets of 4. And again, his form is staying the same, not overextending on the way back, and his neck stays in line with his spine. And the last video is his new 1 rep max at 335 pounds. And he was able to do this on Monday. The biggest thing for him was that his doctor told him that he was probably never going to lift like that again. But that was always something that he knew that he wanted to get back to. And so we've been working slowly on first fixing his form, letting him feel the muscles that are supposed to be activating with these exercises first. And he's learned that it's okay to walk away from a fail, because he failed his second try at this weight. So, and he knew that he could probably try again if he rested a little bit, but he decided that his success up until this point was enough for him, so he was okay with walking away from the weight. And he's had no back pain with any of these things. So these are my references that I've used for this presentation. And special thanks to my CI Mike, the Spine lads, Ken and Tom, and Tony for doing everything she could to get me to have my rotation here. And thanks to my patients, NS, IA, and DF for letting me share their stories today. And thank you to all of you for coming today.
Lauren, if the question is asked, if you could just repeat it, because I know the microphone sometimes.
What?
The microphone sometimes doesn't allow hearing the questions, so if you could just kind of repeat it, that'd be cool.
Oh, okay.
Thank you.
You want me to repeat that one? Yes, if I
It's more of an instruction.
If you ate a cookie, you'd have to ask a question.
Is there a difference between the hex bar squat versus hex bar deadlift, like form-wise? They look like kind of similar. I don't know.
Okay. So he asked if there's a difference between a hex bar squat and a hex bar deadlift when it comes to form.
Right.
So it would just be positioning of the hex bar, either closer or further from your feet. Doing the bar deadlift form for a hex bar is going to look very similar to a squat. So those two are very similar, and they'll probably activate the similar muscles. But as far as doing the conventional deadlift, you'll just have the bar a little bit further up and you'll be further back. So you're sitting more with your hips back rather than sitting straight down.
Got it. Okay. So just move the hex.
Yeah, so you would just
out
move the hex bar further out
for
or
deadlift.
closer,
Got it.
depending on the muscles you're trying to target and the form that you're trying to use.
Okay.
Yes, Tom?
Thanks for the shout out, by the way. I appreciate that. For patients who don't traditionally have any experience with weightlifting coming into the spine clinic or our clinics here, what are some preliminary workouts you might do with them before you feel comfortable with them even using a barbell with even lightweight?
Okay. So he asked what preliminary exercises we would do before putting a patient in front of a barbell who may not have lifting experience prior to coming in here. So there are a lot of exercises that you can do to train them up to a barbell. So either doing like a box squat with just a dumbbell or a kettlebell. Ken also has a really good exercise that doubles as a dynamic sciatic nerve glide, and it basically guides your hips through the hip thrust motion. So that way when you're in front of a barbell, it's kind of the same thing as guiding your hips back and then pulling your hips forward to activate your glutes. And that is done seated at the table with a frame resistance band. So that's a good way to help them train the motion first so they know what it feels like before stepping in front of a bar. And you could also do like supine bridges, lifting up their shoulders and making sure they tuck their chin in by adding pillows or lifting the top of the table. And that is also going to mimic a hip thrust motion, but they're just not going to go back into as much extension before they lift up.
Yeah, I was curious if somebody comes in here and they're petrified of the weights, and they're deathly afraid of them. Is there one or two things that you've normally said to them? Like, what are the one or two things that maybe have worked the best at having them overcome the fear of trying something like that out, or even giving it a chance?
Okay. So the question was things that you could say to a patient if they're fearful walking in and seeing all of the heavy weights that are in here before you have them actually try it. So that was actually like patient NS. She walked in here the first day and was like, there's no way I'm going to be able to do all of this. These weights look too heavy, and they kind of look intimidating. They're giant and round, and they all look like they're the same size. But it was basically just talking to her about her goals, her functional goals, what she wanted to do, and slowly introducing weight to her, especially starting with weight that I knew she could do 3 sets of 10 easily, to kind of just be like, hey, look at that, that was so easy. Let's try going up 5 pounds from there. So for her, I started her on dumbbells first, and then we moved on to the training bar, which is only 15 pounds. So I let her look at it first, kind of get a feel for it, and lift it without any weights on it first. Which I told her it's the same weight you've been doing for your overhead presses. It's just distributed differently. So I had her go up and try it first, and then slowly started introducing weight to her the more she felt comfortable with it. So it was just a lot of communication with her on how she was feeling. If she didn't feel like it was safe, I would demo it for her and kind of stand with her behind her to kind of guide her through the motions, just to show her that her body and her spine are not compromised in these positions. Yes, Mike? Oh, just kidding, Rupa.
Okay. So it sounds like most of your, like the theory of your approach, treatment approach, is mostly strength building. Have you looked at other things like, like you had that one patient with the disc bulges and stuff like that. So would you explore other treatment options before you went into strength training, or like what other things have you also incorporated or have found useful along with the strength training?
So she was asking if I thought about using any other methods of treatment besides just the strengthening for like the patient who had the disc bulges. Depending on how the patient presents, I will start with other things first. The way he presented on evaluation day, he wasn't really having that much low back pain as he was prior to when he first injured himself. Most of the pain was coming from the bike accident that he had, so we started a little bit lighter. We did start with just like the supine bridges and kind of getting him to just do more mobility exercises like cat camel and just child's pose stretches until his legs were healed enough for us to start loading. And it was different for him because he did have experience with heavy lifting before. But depending on how they present, like if somebody came in with sciatic nerve pain, I would address that first before loading them. So making them do like sciatic nerve gliding or tensioners to kind of get that pain to go back more central before loading them on the bar. That's as far as I've really gotten with my 2 rotations that I've done so far, or at least just for the low back pain aspect of it.
I was going to throw into that. I think the other aspects as far as strength training goes is there's a confidence training that has to come up. there has a connectivity building to where the person has to build trust in the therapist who's basically handing their body over to them to try out to make sure that we don't end up injuring it. I think those are strongly considered means of therapy, you know, that may not necessarily be mentioned right off the bat, or you may not be able to see it. But I think strong therapeutic alliance, being able to open up some of the goals that come out of the patient, so that we can focus on pain. We just had another meeting over here with a patient that she was really intent on trying to reduce a lot of the pain that she had, but the problem is it was pain centered. So everything she did was to try to reduce the pain, and I told her that generally, you know, one of my favorite people I like to ask these questions to had mentioned that if you focus on the pain, you'll most likely amplify the pain in the next year or two. That seems to be the trend, but if you focus on the function and make it realistic, that's your best chance of being able to reduce the pain in the future. So she was able to actually kind of hear a little bit into that, but it was more of a conference thing that we had, and I had to build really quick trust in her to be able to offer something like that out, because, you know, now I'm messing with her life. What's the next 2 years going to be like if I wouldn't have listened to him? You know, I'm thinking that maybe there would have been more pain, or now he's having me try these other things that I'm alien to, then I'm going to go for it, I guess. You know, so those are, I think, the evaluation and even just talking is treatment when we do these things. So those are the other options that I think are also valuable, along with strength training.
Yeah, so really great job. I mean, I'm so proud of you. You did such a good job. I think, you know, to Rupa's question, I mean, that's a good question, right? Because you have a lot of different options to treat patients in a lot of different ways. And I think Lauren, the way she presented the pain component and having a sense of what's the predominant pie chart representation of that patient's pain dictates a lot of times what you do. So if it's somebody that's very straightforward, nociceptive, mechanical tissue, then you treat it mechanically. And I think we've had quite a few patients here that have nerve pain. They have, like they're irritable. So sometimes we might incorporate a little bit of manual therapy, and then we progress that to dynamic stretches and stuff of that nature. If somebody's more centralized or fear avoidant, yeah, obviously we're not jumping right into the strength training, but we're setting that foundation for, hey, getting movement and getting you stronger. When we throw everything into a barrel of what we can do, that has the strongest evidence for PT. I'm sorry, that's just what the evidence says. So strength training, getting people moving, some generalized conditioning has the best evidence. So who better to prescribe that than us? So I think we try to mold that. Now, with that being said, I think all three of those patients she presented, not a single soft tissue technique was ever performed. We never billed manual therapy, nor did we bill any modalities. And they were all done within 8 sessions. David's going to come back next week for one more. Oh, DF, sorry. And one of the other patients is coming today for her last session. So, again, I think that should be said. My question to you is, since this is your second rotation, you have one more rotation left, right? Mm-hmm. What are your thoughts about, this is your last week, Friday's your last day. Give me 2 or 3 things that you took home from this rotation that you think were valuable, that maybe you had some in PT school, weren't really clear about, some of the philosophies or treatment strategies, and how that will move you on forward to your next rotation.
Oh man, only 2 to 3. I think the main thing that I've learned is like the different types of pain. I didn't get a lot of pain science as far as learning in school. We were basically taught, and through practicals, everybody was mechanical. Everybody had something that could basically just be fixed with just a quick exercise or a quick stretch, because they had to get us in and out in 15 minutes. So a lot of the practice patients that we had were short standing pain, and it was basically just like, okay, what exercise would you choose? Okay, great, moving on. But here I was really challenged to think about the different types of pain and how they present as a whole in a person. And a lot of times we don't think about the whole person consideration. It's mostly like, okay, how did they get injured? What have they done since then? Or what can I do to get them back to that? But here I've been focusing more on the person as a whole, and not talking to them just about like, okay, well, how's your back doing today? It's talking to them about like, oh, what'd you do over the weekend, and how's your family doing? How's your daughter doing? Like, how's the family doing with all of the quarantine and everything? So I've gotten to know my patients a lot more on like a greater level than I have before and that I would have ever thought about. There are certain questions that I wouldn't think to ask during a evaluation, like, do you have stuff to do this at home, or what's been going on in your life for the past 3 months that might have brought on these changes in pain, or that could have started this pain for you. And just things that I never really thought of as a student. I was definitely looking more at the person now than just having them sit there as basically like a fake patient or like a practical type of situation that I'm used to. Another thing that I've learned is how to dose exercise. I was really bad at choosing good exercises that get straight to the point for the patient. My first rotation basically gave me free reign for exercises, so I had people in here for like hours just doing exercises, ones that targeted one muscle, one that targeted another muscle, and here I think I've gotten better at kind of honing in and doing like, okay, well if I do a squat, that's like 3 muscles in one. All right, that was like 5 minutes, okay, on to the next one. And doing deadlifts, and that targets the posterior chain, so I was a lot better at exercise selection, exercise dosing, and also repetitions in reserve is something that I learned here. So I've gotten a lot better at making sure the load was actually sufficient enough for the patient to be challenged. It wasn't too easy to where there wasn't any changes that were happening for them, and then they were actually leaving here sweating. So I think those are like the biggest things that I've kind of taken away that I'm definitely planning on keeping with me and taking into my last rotation and further on as I graduate.
Thank you.
Good job, Lauren.
And the cookies rock.
Very good.